Check, check, check. 1, 2, 3, check. Assalamu alaikum, everyone, and thank you everyone for coming for this session of AMR supported by Fleming Fund. Apologies for the delays due to the presidential security and everything that was going on in HSA. So now we will start the session formally with the tilawat, and then we can continue it. So first of all, أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم القارية ما القارية وما أدراك ما القارية يوم يكون الناس كالفراش المبثوث وتكون الجبال كالعهن المنفوش فأما من ثقلت موازينه فهو في عيشة راضية وأما من خفت موازينه فأمه هاوية وما أدراك ما هي نار حامية صدق الله العظيم. Again, I would like to welcome all of you to the 11th Annual Public Health Conference. This is something HSA has been organizing after a year gap due to COVID. And we are glad to have this event here. And we are glad to have the AMR theme in it as an area of focus due to the overwhelming interest and also a need in its health system. We can start the session by having a round of introduction. And after that, we will move toward our first speaker. So first I will introduce myself. I'm Dr. Ahmed Hussain Tariq, Technical Lead Health and Population Think Tank and faculty at Health Services Academy. Now, Sir Salman. My area of expertise is microbiology and
Dr. HRH, I'm team leader for the Fleming Fund Country Garden in Pakistan. I'm a public health specialist with a master's in public health. I've been in public health expertise for about 20 years. And my area of expertise is around health system strengthening. So I'm quite glad to be here and be part of this session.
Assalamu alaikum everybody. My name is Dr. Kadir. I'm the Technical Director in Service Street with DAI, Fleming Fund Country Garden, Pakistan. I'm a public health specialist around 28 years of experience in health system strengthening and health policy. Thank you so much.
Can you do this one?
My name is Dr. Hassan Abbas Zahir. I am the WHO advisor on blood safety, and I'm the former project director of Safe Blood Transfusion Program. And I'm doing a presentation on blood safety reforms that we conducted for the last 10 years. I hope you'll join me in that session, which is at 2 p.m. tomorrow.
Please introduce yourself.
Thank you very much. My name is Dr. Nadeem Hassan, and I'm the Senior Advisor for Government Security Data and Service Delivery for USAID Integrated Health System Strengthening and Service Delivery Project. We are working very closely with the Ministry as well as with NIH on AMR as well as Global Health Security Agenda. Thank you.
Assalamualaikum. This is Dr. Taimur Chaudhary, Senior Scientist Bacterium from National Institute of Health. I'm working in AMR project under the current leadership of Dr. Salman, and we are working in close alignment with human health and
Assalamualaikum. I'm Dr. Nazim Prasad, and I'm at National Institute of Health. Dr. Nashna Mahmood, I'm public health specialist. Currently, I'm working as a consultant for the Regional 1 Captura, the International Vaccine Institute.
Wajid. Wajid.
Mute this call. Okay, now I would request our Honorable Dr. Salman to give his first talk as a speaker.
Before I that overview of AMR and health sector, I think I would like to thank the Meet Fund to give this opportunity give this session and arranging this session. I think this is a very important, I would say, important forum where such topics can sensitize because AMR, of course, is a cross-cutting, issue. It's a public health issue, and understanding of this challenge. It's a long challenge for the public health authorities, public health institutions, I think, as well as for other workforce, health-related workforce. So I think, thank you, Dr. Aksha, for organizing this session. I will be presenting an overview of health security. Next slide. So just to highlight the importance of AMR as I think globally recognized as a global health issue now. Like many other diseases, as we have seen in the past 3-4 decades, the emergence of many diseases. Likewise, there is substantial rise in antimicrobial resistance over all these years. And if you look at the themes of the global health security if we look at the themes of global health security agenda, there are 3 themes, that is prevent, detect, and respond. And antimicrobial resistance have been highlighted under the theme of preventing avoidable catastrophes. Next slide. So what, just a quick recap of what is antimicrobial resistance, and most of you might be knowing, but still just to emphasize, that is, it's the ability of bacteria in particular, and then again we have some viruses as well as parasites. But I think that the problem that is associated with bacteria is is really significant, and it has serious impacts on the health system. And these bacteria, once they become resistant, I think they survive the exposure to antibiotics and continue to multiply, for a long time. And not only this, I think such bacteria, they can survive in the environment as well, and then they can infect other people as well. Um, it has the phenomena of antibiotic resistance actually emerged very earlier on in the use of antibiotics, ever since the penicillin was discovered. And for years, I think, especially the fragmented and weak health system with poor regulatory framework, I think such those countries are facing the challenge of antimicrobial resistance as a serious threat. And some of the reasons are, irrational use of antibiotics, and not only in human health sector, but also in the animal health sector as well. Uh, if we look at the impact of AMR on the health sector, I think it has actually threatened the core of modern medicine. There are strong association between antimicrobial resistance and treatment failures, and we have been witnessing these in um, many hospitals. And we as professionals, we discuss a lot of these issues with colleagues who work in clinical setting. There are increased risk of worse clinical outcomes, as well as mortality, and approximately 30% increase in the overall cost to the individuals, and as well as the healthcare cost. Um, Although these antimicrobial, they are prerequisite for preventive as well as curative measures, I think again the judicious use is actually required for both these purposes, preventive and curative measures. Systematic misuse and overuse of antibiotics in human medicine and food products production have put every nation at risk. And we have seen this in, again, I've been giving example in recent talks on AMR, that how as azithromycin was used or is being used by the healthcare professionals, even the consultants, for treating the corona infections. And I think for a country like Pakistan, which has been exposed to, it's having an endemic of XDR typhoid, the use of azithromycin is very, very risky. And I think that is serious concern, because this is the last oral antibiotic that is available, and we have been using it, very, very. It's been used over the counter, and for the treatment of COVID-19. Um, so, without harmonized and immediate actions globally, world is heading towards a post-antibiotic era, and that is the reason why this challenge has been highlighted at very highest level, not only at the WHO or World Health Assembly. I think the AMR has gained attention of the global leaders at the United Nations General Assembly. There have been several sessions in succession for the last few years, where there are high level commitments for combating antimicrobial resistance. Um, this is just a report that reflects that there will be 10 million deaths every year because of AMR by 2050, and GDP will be decreased to 2% from 3.5%, and it may cost up to 100 trillion US dollars. Um, with these background, there was a call for global action on AMR, as I mentioned earlier, and based on the WHO 2014 report on surveillance that was actually about the that was based on the studies which have been published in many countries, and that actually was the starting point for many countries, and in fact for WHO as well, and they subsequently had passed resolutions in 2014 that agreed to adopt a global action plan, which was developed in 2015. Um, I think this is one of very important milestone. I think as far as AMR is concerned, these are quite comprehensive objectives of the global action plan, and it has five objectives with one health approach, and this global action plan demands a coordinated effort by all the stakeholders. And subsequently, the World Health Assembly also asked the countries to develop national action plan by 2017. And likewise, we were able to develop that and present that before the World Health Assembly in May 2017. Uh, so I think just a glimpse of MDR burden. I think the example of these bacteria. I think this is sufficient to highlight the problem. And especially that last one, XDR typhoid. These carbapenem resistant enterobacteriaceae, these are mostly healthcare associated infections, vancomycin, MRSA. So all these limit out our options and to treat such infections, and as a result, it has public health impacts, as well as impact on the healthcare facilities as well as individuals. We actually carried out a study while we were developing the national strategic framework, and some of on a small sample size, but again, the findings were very alarming. Self-medication was very common. More than 50, around 51% people are using antimicrobials as part of self-medication. We have a large number of quacks within the country, and Pakistan has highest number of drugs prescribed, among the highest number of drugs prescribed. That is more than 3 drugs per patient, and 70% of these patients are prescribed antibiotics. And the practice is not only limited to GPs, but also the public hospitals. And the concern is not, I think, about first generation antibiotic. I think they are using all generations and all types of antibiotics without following any proper guidelines. And one of the major, again, problem that requires regulatory concerns uh, is the availability of over-the-counter medications. So we actually think that there are several challenges as far as AMR implementation is concerned. We actually once we started working on AMR, there was no integrated AMR surveillance network that has One Health approach. Still, it's the One Health approach. Although we are working together, I think there is a lot of gaps in integration of the data between the two sectors. We at NIH has as a focal point for global antimicrobial surveillance system. We have been participating in the WHO GLASS program, and we are reporting data from the Sentinel sites on that platform. And there is definitely there are about initially we started with 4 sites, but now that have increased to about 20, and we are working with other sites. But the primary concern is, again, I would like to highlight is the quality of data. And um, as a focal point, I have serious concern on the quality of data that is coming out from these blast reports. But again, uh, uh, personally, I believe that uh, if we have strong health systems, we have strong healthcare facilities, and understanding of the problem, I think the quality of data can be improved, and eventually the outcomes. Um, there are, although there are policies, there are regulatory frameworks as well for prescription control, but they are again not being fully implemented. And um, uh, as I mentioned earlier, over-the-counter sale is one of them. Then there is lack of awareness, especially in general population, as well as scientific community and healthcare workers about the misuse and overuse, um, underutilization. There are several things. I mean, systematic misuse of antibiotics, and then weak IPC practices. Although we don't have a national nosocomial surveillance system, but we are very well aware about the healthcare associated infections as a major cause of morbidity, increased hospital stays, and an increased cost. And that again is linked to the hospital acquired infections with due to MDR pathogens. Uh, One of the important area that is again highlighted in the global action plan as well is to look for antimicrobial utilization and consumption data, and we have limited information about this objective of the global action plan. And our R&D, which actually demands in the global action plan that countries dedicate resource for working with the global communities on development of new products, but our research and development still, limited to applied research. Next. Uh, I think it's personally, in my opinion, AMR. Actually, I think it will be a long process. It's a long journey. Although we have taken certain small steps, I think it will take many years, and the control of AMR in human health sector as well as for other sectors. I think it will take years to to reach a certain level where we can address this problem. And this goes side by side with the health system development. I think if we have a very reasonable quality of healthcare services, especially at our healthcare facilities, I think then we can, be able to successfully uh, uh, take this challenge and address the AMR issues. So, although, as I mentioned earlier, we have been working, we have actually, the ministry has identified AMR as, one of the national health priority. And I always say in my previous talks as well, we actually, before the WHO resolutions were adopted, I think we were fortunate enough to, understand the problem, and we started working on AMR, like designation of focal points, and um, uh, rolling out this strategy, developing strategic framework, and I think these steps helped us in timely development of national action plan. We have a multi-sectoral national oversight committee. Again, the role is quite limited. It has not been frequently, providing oversight, but uh, but this oversight committee is there, and it has a wider PORs, but these committees, although they are not meeting, but we have certain small technical groups at national level, at least I can say, where we sit together and discuss some of the technical areas of the AMR. Um, this is available, that the strategic framework, national action plan, they are both documents are available on the website, NIH website as well. I have mentioned about the NIH enrollment in GLASS for the last at least 4 years. Uh, Through the support of Fleming Fund, we were able to carry out point prevalence survey at selected sites, and we have actually experience of working with the One Health approach for small scale projects. These are the two examples. This is tricycle ESPL project, and Pakistan was one of the 6 countries in the globe which was selected for this project, and we successfully completed this. And right now, the isolates from all the 3 sectors: the human health sector, the animal health sector, and environment sector. Is being done in Denmark. We were able to become part of a another international consortium the National Institute of Health, the National Veterinary Lab probably, uh, for another project that is Carbapenem resistance Enterobacteriaceae project with the same theme in three sectors, and these and as well as the expansion of ESBL project. So we are actually participating in this project as well. These are small projects based on one indicator organism, but I think that they provide insight into the coordination and the need for one health approach that could be useful for advocacy purpose. Um, and we have several, partners which have been working with NIH for the capacity building and laboratory strengthening, like USCDC, Fleming Fund, WHO, and I think the Fleming Fund grant that is, and they have their partners AKU and I think other partners as well. So just to we actually developed the National Action Plan, which was developed in 2017. It was developed through a consultative process, through quite a long workshop, I would say that was 5 days, and facilitated by the WHO regional office, and we identified 7 strategic priorities, and they are in line with the overall objectives of the global action plan, that is related to awareness, behavior change, then establishing AMR surveillance, uh, especially on human animal usage and resistance monitoring, improved prevention control, IPC, and enforcing regulation was identified as one of the priorities, and phase out use of antimicrobials as growth promoters, integration of AMR in all public health research agenda, that is objective 5, and estimation of health and economic burden or AMR for decision making. So these are the priorities, and these documents are available, and if you would like, you can see those documents. So just to just to give you the way forward about this whole process, which and the stage where we have reached up till now. Uh, that has been, that was approved in 2019, but actual funding was released in 2020 because of the pandemic. I think we actually delayed some important milestones. We calculated. I would say
Hello. Can you hear us? We can't hear the audio from your end, so. Hello? We can't hear any audio from your end, so we don't know whether you are, I can see you've projected my slides, but there's no feed, audio feed from your end. Can you hear us? I think others can hear me. Can someone confirm if they can hear me at the conference room?
Nimesh, we can hear you.
Okay, thank you. Is it possible for me to project my slides? I have a live demonstration as well, so it'll be great if I can control the slide slow. So. So let me share my screen in that case, if it's possible. It has been disabled, so some host has to enable the screen sharing function for me. Junaid, probably you have to let me share the screen.
So Nimesh, what I can say is that we have your slides on display. So you just need to tell us to move on and then we can hear you.
Yes, Dr. Asa, but at the end of this presentation, I have a live demonstration session. So that way, it will be good if I am allowed to host as a co-host or if let me the host so that I can do it from my end. Well, if it cannot be, then I can start with the slides.
So they are trying their best to log you in and give you control.
Thank you very much, Dr. Asa.
Excuse
anyway,
me? बच्चे जरा इधर आइएगा.
I think I am
Please आप
now
बच्चों
the
को
host.
कंट्रोल में रखें, ये खेलने की जगह नहीं है. हाँ? नहीं मैंने ऑफ किया, म्यूट किया है.
Good, Godwin.
Can you see my screen now? Hello, can you see my screen now? Hello. Yes, I think you can see my screen. Anyway, let me continue. Thank you everyone for allowing us to represent Captura in this workshop. I'll be happy if you let me know if you can hear me. If not, I can repeat the presentation also, but I'll not take further time and continue. Just a brief introduction. I'm Dr. Nimesh Podel. I am from International Vaccine Institute and representing Captura, the regional grant of Fleming Fund for South Asia and South Asian region. And I'm the focal person for the South Asia region, so I'll be more focused on the South Asian perspective of Captura in this presentation. To begin with, Captura started its activity in Pakistan in November 2019 with a scoping visit to Pakistan, where we met different stakeholders in AMR, working in AMR in the country, including Dr. Salman and his team at NIH, Dr. Akram, and Dr. Aisa as well. That was the beginning of the Captura activities in the country. But before moving to the actual Captura, I would also briefly like to highlight the Fleming Fund portfolios that we are representing. You must be aware about 3 different portfolios of Fleming Fund, the regional grants, the country grant, which DI Pakistan is leading in Pakistan, as well as the fellowship scheme. We are the Fleming Fund regional grant, Captura, and IVI is leading, the International Vaccine Institute is leading 2 of those grants in the region, as well as it's participating in a 3rd one. The Captura being the first grant, which is basically dealing with the collection of historical data and capacity building activities in the country in South Asia and Southeast Asian region, whereas there is another grant called Radar, which is basically focused on policy and advocacy on AMR. There is a 3rd grant, which is being participated by, IVI is a consortium member for that, which is led by DTU in Denmark. It's called EQ Asia grant, which is basically focused on the external quality assurance in clinical laboratories, clinical microbiology laboratories in health, human and animal health. Just to let you know, Captura is the only grant which is only focused in human health, whereas RADA and EQ Asia are One Health approach grants that are being implemented. These are the countries where Captura is working on. In South Asia, it's Nepal, Bhutan, Bangladesh, Sri Lanka, Indonesia, and technically Indonesia is here in South Asia, but in our context for ease of work, we have included Pakistan in South Asia. That is for because of the geographical proximity and ease of working in that region. Though in typically Southeast Asian grants includes Pakistan in this case. The objectives and aim of this grant is to expand the volume of historical and current data on antimicrobial resistance and diseases in Africa, in Asia, both South and Southeast Asia. We technically approached the countries for a collection of data, AMR, AMU, and AMC data from 2016 to 2019. Where we identified, collected, collated, digitalized, graded, and are now in a process of analyzing and visualizing those data that have been collected. And in addition to that, we have also been supporting the countries, the country grantee on capacity building activities while we are implementing Captura related activities in the country. In Pakistan, we basically approached the country in November 2019 and then introduced Captura to the countries. Conducted initial visits for the approvals that are required, or introduced the project to the country stakeholders. And then we moved on to map and identify the data sources in the country through different scoping visits as well as data sub-analysis. And then we in the meanwhile, we're in the process of determining the gaps in EMU, AMC, and AMR analysis and data visualization. That is one of the important aspects of surveillance where people must be aware and should be it should be presented in a form that everybody understands what the data represents. That is where we were looking forward to visualize the data and support the countries. And that's where we are now focusing this presentation on how we can present and visualize the AMC data that has been collected. Also, we've been supporting the country through the country grantee on different aspects and focusing mostly on the capacity building activities by providing HUNET training. We're able to collect some of the exemplar data, EMR data from some of the sites which were ready to engage in data sharing agreement, and we'll be analyzing those data and sharing towards the end of the project, which is running till 2022. So right now we are still in a process of analyzing the data, and this is the interim findings that and progress that we're presenting at this moment. There is another project, as I said earlier, which IVI is leading, that's called Radar, which is very active in the country as well in the region. And we are currently doing a series of webinars and workshops to advocate for development of policies and regional data sharing in this area. So that is where we're also supporting, Captura is actively supporting that project also. This is just a snapshot on what happened and what's happening through Captura. We are working in 5 different countries in South Asian region. As I said earlier, we included Pakistan in this table because of geographic proximity and work related activities. But later on, when we report it in the South Asian region, Southeast Asian region reports. And just to let you know that we've been able to collect a large number of EMR data from Bangladesh and Nepal, and also we're able to reach out to some of the private sectors in Sri Lanka. In Pakistan, since we initially our scope included exemplar data sets, and that's where we were able to only collect EMR data from 3 sites in Karachi region only for visualization purpose and analysis purpose. Whereas in Bhutan, we were able to collect 100% of data, but they have a very minimal number of facilities generating AMR data, and we are able to reach out. So the scope in different countries differed, and we were able to reach out and engage ourselves as per our scope and capacity. Also in Pakistan, we were able to, with the help of DAI Pakistan, we were able to get a hold of the IQVIA AMC data, and which I will be demonstrating on our analysis what we did, and with the help of the visualization tool dashboard that we created shortly. This is just an approach what we took. We did kind of a questionnaire survey in almost all the countries where we reached to understand the existing capacity of the country, and also we did kind of a rapid assessment of those data sets that had been collected to ensure that whatever we are collecting of quality data, and we were able to break the data also just to make sure that the analysis outcome is standardized and is valid. We are still in a process of analysis, but probably by the end of this quarter, next quarter, we'll be able to get some reports out of the data we have collected and the metadata, and we'll be able to share share it in the regional forums that we're planning to have towards the end of the project. Capacity, in terms of capacity building activities, we are supporting through DI. Again, I'm very thankful to the country grantee here that they are very much supporting and including us in all of those activities that have been happening in the country. And we are providing training to HUNET training to human and animal health, even though our scope included human health. We were able to support the trainings, HUNET trainings in the country. This is currently in the pipeline. We are trying to visualize the metadata that has been collected in the entire region as well as from the Pakistan. As I said, we will be coming up with a report towards the end of this year and share it with the country stakeholders to a different meeting where we will be identifying or sharing whatever has been identified, and probably will be discussing on how it can be utilized for the next steps in the country. This is the tool that we use for metadata visualization, and we will be using MahuNet for AMR data analysis and report preparation. But what I wanted to focus in this presentation is the Captura tool, which is a tool which is developed by Captura on AMC data visualization. In some of the countries, there is already a dashboard available for AMC, but for those countries which does not have, I think this tool will be valuable in terms that this will be made available freely in the internet once we make it live, and anyone with a minimal expertise in IT and microbiology or pharmacology can curate their data and use it for the visualization of the data that they have. It can broadly be helpful for those countries where they are planning, which are planning to introduce dashboards for AMC in future, as well as for smaller sites in the regional level also within the country where they want to have a annual or comparison between the regions, as well as comparison between the years where AMC data is available. Just to show you what it looks like, this is where I will now go live. I'll first start with the dummy data that I have created. We created for this particular demonstration, where the dummy data is not representative, or it's not for any country, but it's for simply to show that how simple database, how with a limited number of database we can create a dashboard, and if there is one dedicated person in the country who can look into those databases or create those databases, will be able to simply generate this dashboard with the help of the tools that Captura is currently preparing. So this is just an example. If you can see, there are only very limited number of columns with the data that is required. It includes country, district. If you have a district level data, granular data available, then the codes, ATC codes for the antimicrobials, then the substance name, then pharmacological subgroups, what is the route of the administration, which class of where they belong to, and the year, as well as the final information that they have. We have in this is the DID. If I put it in a dashboard that has been created by Captura, that is currently being created by Captura, it will come out to be like this. This is actually the data that has been that is available in that particular set of Excel, and this is how it will be visualized if you run it through this tool that has been developed. It will give you a DID at the national level, and if there is what do you call it, the granularity at the district level also, then you will be able to see the DID and compare it within the years at each district levels also. Secondly, you can also have the data visualized for a particular year also, or compare between the year. If you want to compare between this 17 and 18, then you can do it also by this removing the 19 data. So this is, and you can add the number of years to this particular Excel sheet, and it will be automatically generated. The dashboard will be automatically generated by this tool that has been created. Another important thing is that if you select the district level, it will allow it to be compared between that particular district and the national level data, the DIDs also. It will allow the use of aware category. It will show the use of aware categories between the district and the national level. And you can also see it in a percentage level also. If you just switch, toggle this switch, that is available on the side of this tool. And this is the AMC by pharmacological subgroup, DID. This is the PID, whereas this is the percentage different anti-pharmacological subgroups that are used in 17 and 18. So if you would select all three levels here, all 3 years here, and a national level, then it will show it for the national level. Whereas if you select it for just district or some years, then it will show it for those districts. So it's a very interactive, very user-friendly, and also I'll now show you how to generate this table, generate this dashboard using the data that I showed you earlier. So this is where I think this is the data that we had now. If you simply go or use this tool that is in the process of development, it's not already live, but if it's in the process of development, you see it is very easy to upload this data. There is a function that says upload the data file, a button which says so. You just simply select the dummy data. It should be CSV file and in the format that has been shown. And then you can say that it's like Himalayan country. It's a country name. So if you do it and just click a preview, the dashboard will be automatically created. So this is very simple and it's very user friendly. It's only important thing is that you just have to have a basic IT knowledge and basic knowledge on how to maintain that Excel sheet. And if you keep on adding to that, it will be able to give you all the information in a format which is readable and easily understandable to the people. And it's also locally applicable or locally installable. So you don't even need an application to download for this process. It also will with this tool will also prepare a SOP on how to create those files, Excel files, and also we have included a large number of frequently asked questions and what each section means, each items means in this tool so that it's easily understandable and can be used. So this is what I think if it can be of help for countries which has not already used or started their dashboard for AMC data visualization. And that is what we wanted to highlight in this presentation, as I think AMR not only includes AMR, but it also includes AMEA and AMC surveillance. And there is where we can capture, can add on to the existing activities that the current countries are leading, including Pakistan and AMR containment. Finally, to conclude my presentation, that's where we are supporting the countries and the reason in interactive mapping of the AMR data. This is where we find also. And then at the end of the day, our aim is to increase the local data analysis capacities for AMR containment. That's the added value that Captura is proposing. And at this hour, with 3 projects that are currently running, we want to create a baseline data in the region, and with the help of EQAsia and Radar, advocate and develop a policy for AMR containment at the regional level, especially in South Asia and Southeast Asian region. Important thing that I'd like to highlight is that there has been a very good response about interest also about data sharing between the stakeholders, especially the data owners and data generators in almost most of the countries where Captura is currently working. And we have seen that there is a need for a regional networking also, which can be discussed further beyond Captura, or be discussed between the countries also, and see if that helps in containment of AMR by sharing the information of outbreaks as well as sharing information of the current patterns in the country. Also, we noticed that there is a huge gaps in data visualization, and most of the activities that are currently ongoing in most of these countries is focused on AMR, or let's say the laboratory-based AMR surveillance, where AMU and AMC are not being taken up mostly. So I think these are the areas also that needs to be highlighted and taken up. With that, I'd like to thank everyone, and I'll be happy to take any questions if you have. Thank you very much for your time and patience. Please, if you have anything, I'm here. I also have Dr. Marian Holmes, who is leading this Captura project, and Asia from IVI end, and we'll be happy to take any questions if you have. Hello, I can't hear any one of you. If somebody is speaking, then probably you need to type in if there is any question. I'll be here throughout the day till the end of this program. So if you have any question, please feel free to drop me and I can answer it. Okay, I can see Junaid responded. Thank you. So moving on to next. Thank you. I'll now hand over the host to Junaid in that case. How do I do that? Sorry, I'm trying to do it, but okay, Junaid, now you're the host. Thank you very much. And I'll be happy to take anything by afterwards. Have a good day.
Hello, everyone. Good afternoon. Thank you for inviting me to this annual public health conference. My name is Dr. Samuel Urubu, and I'll be presenting on behalf of Professors Mohammed Saman and Veronica Witt from Boston University. I would like to share my slides now. Please, Junaid, can you enable slide sharing? Thank you. Give me 1 minute. The title of my presentation is the Antibiotic Footprints Project, Pakistan. Before I go further into details, I would like to introduce the contents of the slide and of the presentation. First, I will give a background introduction to the Fleming Fund, mention the consumption partners. Then I go on to the Antibiotic Footprint Project itself, and we will look at the background for this project, the goals, methods. Then we'll end with results, key finding, and policy implications. Policy implications mostly for the human health sector. In 2016 or 2015, a panel that was set up in the UK to assess the threat of antimicrobial resistance found that by 2050, if no containment efforts were initiated, the world could have up to 10 million people dying per year from drug-resistant infections. The burden of this would be in developing countries in Africa and Asia, which combined are expected to contribute up to 90% of these deaths, meaning that this is an urgent threat that needs comprehensive solutions. The impact on the global economy was predicted to be around 100 trillion USDs. And antimicrobial resistance itself singularly could jeopardize the Sustainable Development Goals set out for attainment by the United Nations by 2030. The Fleming Fund is a global UK aid program trying to address threats to antimicrobial resistance by improving AMRO surveillance, strengthening national capacities for surveillance, and also improving the collection and use of AMRO data in line with individual countries' national action plans to inform policy and delivery of healthcare. In Pakistan, the Fleming Fund works with a number of partners. In total, there are 6, 5 of them, the DAI, Indus Hospital, Arkan University, Health Security Partners, and Liverpool School of Tropical Medicine and Hygiene joined earlier, and Boston University joined early this year. So, what is the antibiotic footprint? The antibiotic footprint was modeled after the concept of the carbon footprint. And in itself, it visualizes after estimating a country's antimicrobial use. If we see the schematic on the right-hand side, on the left in that figure are all the components contributing to increase carbon dioxide concentration in the world. On the right-hand side, we see those sectors that this antibiotic footprint analysis should cover. Essentially, all the One Health sector used in hospitals, community pharmacies, agriculture, including the use in companion animals. So in essence, the antibiotic footprint is designed as a global communication tool using evidence to facilitate practice and policies aimed at antimicrobial use reduction, which is one strategy that has been proven, especially in the European Union countries, to reduce the threat of antimicrobial resistance. The goal for this particular project was to create an antibiotic footprint for Pakistan, and that consisted of 5 interrelated objectives. The first one was to map the human and animal antimicrobial supply chains to identify the main data sources of antimicrobial consumption, and then to assess the gaps in these data sources to enable us to estimate the consumption for Pakistan in animal and human health sector, and then subsequently to visualize this consumption as a tool for facilitating policy interventions to address AMRO. Overall, we divided the project into 2 phases in terms of methodology. In the first phase, we conducted a situation analysis of data sources to identify data sources and owners. And we did this via 3 different approaches. One was a scoping literature review. The second was by key informant interviews with stakeholders in Pakistan. And then finally, mapping of the supply chain. The second phase went on to estimate antimicrobial consumption in the human and animal sectors. The results from the situation analysis will be presented in the following slides. In terms of the literature review, we searched 4 databases, finding those articles that I mentioned, but at the end, selecting only 7 articles. Now, the basis for selecting these articles was in answer to the question, what national level antimicrobial consumption data was available in the literature? These 7 articles, as you can see now in the table, used a number of different methodologies. If you look under the column highlighted in blue, these methodologies, by and large, were similar. PPS in this column refers to point prevalence survey, which is a WHO recognized tool for assessing the prevalence of antimicrobial use cross-sectionally at one particular point in time. It can also be longitudinal. IQVIA, as we see in the table, and as we will refer to later in this slide, is a private sector market intelligence company. So by and large, the methods that are used across these 7 studies are similar. It should be noted, though, that we did not find any single study that advances our understanding of the national level consumption of antimicrobials across the animal and human health sector. Looking at the last column in this slide, we see the different data sources. Again, we will come back to these data sources and implications for policy later on in the slide. Moving now to the key informant interviews. We performed interviews online or over the telephone with various key stakeholders in Pakistan, covering government officials at the federal and provisional levels, including Ministry of Agriculture, provisional ministries of health, with officers who are responsible for antimicrobial resistance data collection, and some also perhaps antimicrobial consumption data, including also the leadership of the Pakistan Drug Regulatory Authority, as well as medical professionals. All of this was necessary to identify what data sources are available and how accessible these were. We are yet to conduct the interview with experts from the pharmaceutical industry to also understand their contributions or viewpoints. Now, moving on to human sector supply chain and data sources. The boxes that are colored in gold or orange represent potential or existing data sources that could inform attempts or efforts to estimate or to measure antimicrobial consumption at the national level. I will highlight only those boxes that appear in orange color. Here we see PPS. For instance, at the bottom of this chart, on the right-hand side for public healthcare facilities, potential data sources are as listed. Pakistan, we're aware, either at the provisional or federal level, has started implementing the district health information system, called by different names at different provinces, which ideally captures or ideally ought to capture consumption as well as other indicators of healthcare services in public healthcare sectors, be that primary healthcare, secondary, or at the tertiary level. That information is there, even though we could not yet get access to that because it's publicly controlled. But the PPS, point prevalence survey, for these healthcare facilities are not so common as we would have thought, especially now for the primary healthcare sector. The same thing too you see on the left-hand side of the slide for private health facilities and pharmacies. We could not find any record yet of PPS or also of prescribing data or, of prescribing or dispensing data, we will see the value of this later on in measuring antimicrobial consumption. So this is just the summary of what we found for the animal, for the human health sector, supply chain and data sources. Similarly, for the animal sector data sources, you'll see at the upper level of this chart that at the level of the importers, you have the import data from customs. This data is available from private data sources. You need subscription. Perhaps customs might also have a comprehensive data, but this was not publicly available to us. So we had to use indirect import data suppliers who claim to source their data from customs. At the level of the manufacturers, manufacturers are supposed to also provide production and sales data. We heard that this is available, but we haven't really yet had full access to this data. So again, as for the human health sector, the boxes in gold represent data that are potentially available, and the ones in orange represent data that should be available or could be available, but is not yet fully available. We know at the level of the farm that used data has been collected in a survey, as part of a survey under the Fleming Fund, but at the national level, we don't think that that is done countrywide. So the key findings from the situation analysis are that Pakistan, with the size of its human and animal sector and the efforts that are being implemented to measure consumption, could well serve as a model for other countries, and that there is a strong research sector interested in bringing data-driven policies into play, as well as development partners and the governments as well. But challenges remain, and these are principally in data sharing agreements between institutions, or you could say an apparent lack of linkages between institutions, especially when it comes to antimicrobial consumption data. Also, we found that data quality from the import data sources, which we use principally for the animal health sector estimation, as you will see later, is it's challenging because it's not structured, and there are some issues with the use of that data, specifically now in the case for the import data. Moving on now to the second phase of the project, which was the estimation of the antibiotic consumption. The human sector data is supplied by IQVIA. As I mentioned, these are this is a market intelligence company. But even in the human sector, IQVIA has access or has data that covers only 85% of the total market. And this 85% is the private sector antimicrobial consumption data. Yet, we do not have a form covering the public hospitals constituting the remaining 15%. We do not have that data in a form that perhaps could be publicly shared or analyzed. So the analysis we have done here, BU and Fleming Fund combined, who relates to this 85% at the moment, even though we are designing or trying to develop other methods for completing the remaining 15 under this project. So the figures that we have for antimicrobial consumption, I'm using the word antimicrobial and antibiotic interchangeably. The figure we have for the human sector was, in terms of the total consumption, was 35.46 DID, where this is daily doses per daily defined daily doses per 10,000 inhabitants per day, which is a metric proposed and being used globally. Now, we should also note that this figure is also provisional and subject to review. But in terms of pattern of consumption, we found that the macrolide, cephalosporin, tetracycline, and penicillins, so this is the macrolide, cephalosporin, and tetracycline classes, as well as the penicillins, constitute about 40–45% of total consumption. Leading consumption in Pakistan is the use of the quinolones or fluoroquinolones, constituting or comprising about 45%. What is the impact of this prescription pattern on antimicrobial resistance, and how does this relate to consumption? If you were to compare this pattern of consumption as well as total consumption with other countries, where does Pakistan stand? And what is the implication of this information? We will see that in a subsequent slide. But now we go on to the animal sector. It is necessary to note that in the animal sector, antimicrobial use comprises the therapeutic use for treating illnesses, as well as the prophylactic use or the use of antibiotics as growth promoters, packaged or manufactured as feed additives. So to understand antimicrobial consumption in the animal sector, one needs to pay attention to both those products that are imported as antibiotic active ingredients and finished products, as well as those products that are imported as feed additives. The data source we have used now for this import analysis is a Pakistan Exim Trade Info, but there are also other private data sources. Generally, the strength of using import data is that it is accessible if you can pay the subscription fee. And usually this data covers a number of years, and that could enable one to do a trend analysis to see how consumption changes over time if you want to identify benchmark consumption and then track this over time to see what effect policy changes might have had on consumption over time. Well, this relying solely on import data as a means of estimating consumption could easily lead to overestimating antibiotic use, because if you focus on a particular year, you may not have the benefit of knowing whether all those imports were used or consumed in that particular year. It is also sometimes difficult to stratify. Stratification here could be twofold. On the one hand, to say these are products that are meant for use only in the animal sector, in as much as animals and human antimicrobial use includes certain APIs that are used in both sectors. The import data does not make this fine distinction, so it's a challenge to completely separate animal from human uses. It might also be difficult to completely provide figures for APIs that are subsequently used as feed additives. So these are some limitations with the use of this data source in the animal sector. The focus of our part of the work was to look at veterinary sector antibiotic consumption. As I mentioned earlier, we had done the landscape data source landscape analysis. At the moment, we are computing antibiotic consumption in the animal sector. The question mark there is deliberate in the sense that even though we do have a provisional figure, I have redacted it in these slides to stress the point that we are still in the process of verifying that figure. Antimicrobial consumption in the animal sector could be expressed as a number of metrics, and this milligram per kilogram of live animal weight or biomass is simply one measure. It could also be expressed as milligram per PCU. So hopefully before this year runs out, we should have that final confirmed figure, confirmed as much as possible based on availability of data sources at our disposal. But in terms of the top 5 milligram per kilogram consumption, we found neomycin, tylosin, doxycycline, and the other 2 listed in the slides in terms of decreasing order being the most frequently consumed. To summarize, the findings from the consumption estimation in the veterinary sector, this project as a whole provides an opportunity for a first approach to estimating national level consumption in all One Health sector in Pakistan. But there are challenges that we face. As we mentioned earlier, this is the complexity of the data sources and in terms of stratification. To conclude, what are the policy implications of this preliminary data for Pakistan? So here we have tried to benchmark consumption using data from the European Union or the EEA. The European Union of all the regions in the world seem to have perfected antimicrobial use surveillance and estimation, and therefore sets a kind of benchmark or standard for other regions of the world, and that's why we've included it in this analysis. So looking at the figures for 2019 in the EU, this is the average consumption in terms of DID in human on the left-hand side. Across the countries that were reporting data for 2019, the average consumption was 19.4. Placed against the provisional figure for Pakistan for the same year, we see that this is almost 2 times at 35.46. Howbeit, it should be noted that in European Union, Greece consumption of antimicrobial consumption in the human sector, this comprises now hospitals and the communities. Remember, for Pakistan, we're saying we only have data for the private healthcare sector, but for Greece, this is across all facets of human consumption, as well as in the EU. For Greece, the figure for 2019 was close to this for Pakistan at about 34.1, but has shown a decline from 2010. For 2010, the figure was much closer to what we see here for Pakistan, about 35 DID, showing that even in Greece, that has the highest consumption in Europe, there has been a declining trend in consumption as a result of efforts that have been put in place to reduce antimicrobial consumption. On the other hand, in the animal sector, the figure for 2017, as released by the OIE for many countries around the world, show an antimicrobial use or consumption in the animal sector of 117.48 milligram per kilogram. It will be interesting to see what the figure for Pakistan is, even though that might now be for 2019 as opposed to 2017. So in essence, and to summarize, measuring and estimating antimicrobial consumption, especially under this antibiotic footprint project, enables policymakers to understand antimicrobial use at country level and to initiate or develop policies and practices aimed at checking or reducing antimicrobial use, which have been shown to be a useful strategy to address the global threat of antimicrobial resistance. I would like to end by acknowledging others who've worked with me on this project. As I said earlier, this was a presentation on behalf of my supervisor, so that's Professor Mohamed Saman, Veronica Witz from Boston, as well as a colleague, Hassan Fusil. On the part of Fleming Fund Pakistan, we have worked very nicely with Farouk Tahi, Usman Saeed, Aisha Rashid. Thank you very much.
Thank you very much. I'm not sure you can hear me or not. We would like to move to the next speaker as we are already very short of time. So IT, please write the text that the next speaker will be Professor Dr. Mo Salman, and he's ready to start presentation. Please shift the host control to us.
Yeah, I cannot share my screen. Can somebody help me with that?
आप होस्ट का कंट्रोल देते हैं
I need to be authorized to share the screen. It's
इतनी presentations का folder खोले ठीक है इन्हें host rights थे foreign होस्ट राइट में वापस मिल गया उनसे पुराने स्टूडेंट को रिक्वेस्ट कर देंगे सर काइंडली गिव अस बैक द होस्ट राइट्स
Maybe in the sake of the time, I will not have slides. I could go with the presentations without the slides, if that.
IP हम उनकी presentation को start कर देते हैं और if we can share it from our side.
Okay. No, the host has to disable the or unable the share the screen. It's still disabled now.
Can you force among participants? Can somebody call Professor Dr. Samuel that please give us host rights back? We cannot do it.
It must be a co-host. It cannot be.
Right now he's the main host. Dr. Samuel का नंबर है किसी के पास?
Well, it's
Dr. Mo Samuel की presentation पढ़ी है?
Okay, I will go with that. I also sent the slides presentations to the organizers, so either they could.
Screen share करते हैं और start करते हैं.
Okay, now yes, well.
Please कोई someone Dr. Samuel call कर दे के host एक समय मिलवा दे.
Well, I like to thank the organizers for allowing me to give my a little bit, I will call historical and philosophical discussion about the concept of One Health and its relation to the AMR, but also on the role of veterinary medicine in that respect. So my presentation is not to have anything related to current research or data presented as the previous two speakers, but I will like to say is that doesn't mean I will not in position to encourage and promote this type of projects and to complement that. Next slide. I like to go back to the history in the late or middle of the 1800s with a wonderful physician, but also a philosopher. German one is the Rudolf Virchow, who said, like, between animals and human medicine, there is no dividing line. And the object is different, but the experience obtained constitutes the basis for all medicine. And that's really like what it could be cover what we are talking about, especially related to the antimicrobial use and therapy, as well as the resistance in that respect. Next slide, please. So it's what is One Medicine or One Health, and how it started is, as far as the history is, next please, the first person who used this one, or the first scientist, William Osler, who was a Canadian physician, and he started the first vet school in North America. So think that way, a physician and start vet school, but also he was a son of a butcher. So he used a lot of his experience from his dad, but also his knowledge in medicine to understand the link and the pathology of the different diseases by using animals as a model. Next slide, please. then I like to say, well, is later on, Daniel Salmon, who was really that where we call Salmonella, was the, as a veterinarian, how he initiated a lot of the principles of the what Pasteur led to the microbial agents and its relationship to the causing diseases in that way. And he used it both in humans as well as in animals in that way. Next slide, please. And then we have the Theobald Smith, who was not even like a physician or a veterinarian, but he was a great pathologist, parasitologist, who worked on the blood parasites to understand the relationship between infection and disease, but also in relation to the ecological aspect of the host in this situation, mainly in cattle and in that respect. They are, in my opinion, the leaders in public health in that respect. So one medicine and one health has many definitions. Next slides, please. And next slide. And in many definition and interpretation, especially during the last few years, it were, in my opinion, sometimes abused because it's really like anything and they link it to one health, but sometimes they are narrowing it to only the zoonotic aspects of diseases in that respect. Next slides, please. So one definition I found very good for the One Health is what is AVMA, the American Veterinary Medical Association, initiated in 2008, in which, like it's indicated, is the cooperative efforts of multiple disciplines. And that's very important, is the cooperation, but also the disciplines, and working in different environment, locally, nationally, and globally, and mainly to obtain optimal, is not maximum, optimal health for people, animals, and our environment. Next slide. And when you think about that, is mainly that where the function and the operation of the profession of veterinary medicine. In general, it's really covered by this definition. So it's nothing new in terms of the practicing veterinary medicine in different areas, but it's mainly now linked to the aspects, so it can be like more and like applicable to the society in that respect. Next slides, please. So animal health and is linked to the human medicine. Its first charge to of the veterinary medicine was mainly is human health. And a lot of people could not recognize that, but historically, veterinary medicine started because of the interest in the human health and the link to the animals, and specifically at that time related to either the work animals such as horses, or also to the food animal in terms of spreading diseases from these animals to humans. So that's, I think it's very obvious, like we are looking in that respect. Next slide, or next hit. During the 20th centuries, and especially like in the end of the 20th century, cooperation between the two disciplines, the human and the animal side, getting diminished for several factors. I don't want to elaborate on it and now in my 20 minutes discussion. But unfortunately, we became so much a separation in that respect, and a state of working together in that respect. So I'd really like to say is like next slide, please. One of the leaders in the One Medicine, or what is called at that time One Medicine, and then later become One Health in veterinary medicine, is my mentor, and I'm proud to say that, is Calvin Shuabi. I like to maybe mention about like a little bit about Shuabi in that respect. When he started to, especially in the late 60s and 70s, to associate like veterinary medicine with agricultural production, and how it tried to build the field of preventive veterinary medicine as the base for establishing that. And that I really think is a wonderful, I would like to say, cornerstones in moving veterinary medicine in respect to the application of the One Health and One Medicine in that respect. Next slide, please. When we talk about the antimicrobial resistance, is really a wicked problem. When I say the wicked problem, because once you open any dimension of it, or any respect, or any component of it, it will open a lot of other issues that need to be solved in order to combine everything together. And a wicked problem, that doesn't mean like we should ignore it, or we should say, well, we cannot deal with it because of the complexity of the system. We should try to understand the complexity as much as possible, and try to attack the different gaps and issues to lead to a solution in that respect. And next slide. For that aspect is, I like to say is the AVMA, again, the American Veterinary Medical Association, initiated a committee on the antimicrobial resistant pathogens. And I just extracted one sentence, long sentence from it. And you could see from that slide is like the One Health approach was recognized but by this comprehensive committee that is the best way to come and interconnections of the health for the people and the animals and the environment. That's where I think it's the issue will come in the picture. And that's where it started by building what I like to say is the need for baseline for the antimicrobial use in animals before we start to think about the solution for the resistance. Next slides, please. I would like also to say this is not only like in North America or in United States. FAO initiated a very good, like a group of scientists. They put them together and produce a very good report about the what they call slowing down the superbugs, and mainly like talking about the antimicrobial resistance. And I like you to pay attention to the conclusion from that there is a need for the analysis and strengthening the relevant regulatory systems. Here we talk from like not only the use, but how we can build policy and regulations to identify and also to solve the issue related to the AMR in that way. And I like to get your attention to the last sentence in which like they try to use the AMR, at least they suggest the use of MAR as a legal framework for they need to be considered as a whole in terms of solving issues related to the animal health, but also human health in that respect. Next slide, please. So what are needed? And I really think that's where I feel like it's very important. The scientific evaluation is required. In my opinion, is the comprehensive assessment. The current project, the Fleming project in Pakistan is a very good example of establishing a baseline information and data related to the antimicrobial resistance. I think is the previous two speakers I was listening is really a good example about this need for the comprehensive assessment. I will emphasize on the issue about comprehensive. Each of those will be a component, but we need to get them all together to be understood in that respect. Next slide, please. And there is need for baseline data. As I said, like the comprehensive assessment will require that. I like to say, well, again, is using the Danish experience, and I'm not saying that's the only experience, but the Danish public health and animal health work together in order to establish a baseline data during like a few years ago, and really like a good model to be utilized in other places such as Pakistan. And I think is the Fleming project in Pakistan is based on that type of experience and how to build on reliable baseline data that is not needed. Next, please. And there is also a need for revision of how for the options on how to use any type of prophylactics in veterinary practice. It's usually like we need to think about advancement in the scientific and the technological knowledge now instead of staying with the conventional way, because sometimes, or at least historically, antimicrobial therapy was used on a mass prophylactic aspect as a prevention, and that one is really need to be reevaluated and try to approach it from the advancement in the scientific knowledge that we have now, and we know about the impact on the environment, but also for the next slide, please, for trying to accept the veterinary practice and its contribution to the antimicrobial resistance, mainly through the mass use of the antibiotics for a prophylactic aspect. So that type of accepting the fact is very important instead of being on the defense side all the time. Next slide. Okay. So what is needed in terms of the involvement and being in the proactive in the engagement? One thing, next slide, is there is a need for reliable information, and this is almost I repeated from the previous slide, and that one, it will require participation in the collection of the baseline data in both human and animals. And I would like to also to add is also even in the plant diseases in which like they are utilizing some of the antibiotics that just need to be included. Again, I will emphasize like the current project in Pakistan is a good example of collection of the reliable data. Next slide, please. But we need to stay also within the limitation and constraint of the antimicrobial therapy as per the instructions from the Manufacturing and Regulation Agency. That one I can tell you is being abused in some of the veterinary practice and need to be corrected as much as possible if we want to stay with the proactive. Next slide. We need to explore alternative options for the how to be combating the pathogens and parasite, and not to stay only with using of chemicals, or also to look at it from holistic approach as much as possible. Next. And we need to monitor research findings. Research findings, especially during the last few years, has advanced in using of the antimicrobial therapy, and we need to see how we can apply that in the practice as much as possible. And I'm talking about like in veterinary medicine in that respect. but be also less on the defense side, as next slide, please, less on the defense side in the contribution of veterinarians and animal scientists and their contribution to the overall impact of the antimicrobial resistance. Next slide, please. And for that purpose I feel like there is what is called in business inflection point. We need to think like we are in a position of inflection point in the therapy and prevention in both human and animal side. And we need to think about a different way of operating and a different way to establish business in that respect. Next slide. And that's where I think is where I feel like the university, especially through education, can contribute in by moving away from the conventional education and moving to a different way is through the strategic strategic inflection point. And really, like, this is where I think is a wake-up call for the university to be involved. And the next slide is, or next point is this is in business, what is called the 10 X factors we should consider. And I'm not planning to elaborate on that, but mainly to consider the university and the education as a business. And we have customers, but we have providers that need to be considered in that way. And specifically when it comes to the veterinary medicine, but also in human medicine in that way. We should stop, next slide, from the competition in such way and try to work together as much as possible in a team approach so we can reach a solution and serve the society and the community instead of just staying in our environment in the university and not to know what's going on outside. And next slides, please. And that means the demand for the society and should be willing to serving as much as possible. Next slide. And so there is the need here is mainly that both university and professional education system should consider a new approach for delivering teaching material to the students. Get out of the environment in the classroom. Try to understand the real problems in the world in that way. And being an educator for the last 40 years, I think I should be blamed as the others. We need to be more listening to our both providers and the customers in that way. We should move from being teachers to facilitator in the classroom, and especially with all of the way now, the information and the flow of the information and through the technology and the internet, that we should not repeat it what the students know better than us from just through Uncle Google instead of like move and try to repeat textbooks in that respect. Next one, we should try to work interdisciplinary and instead of multidisciplinary for the health protection and the social changes are needed for that respect, and that's including the antimicrobial resistance. Next slides, please. So it's the way is when I said conventional, when you look on what has happened with the three components, in my opinion, that is they are operating in silo in teaching, research, and outreach. Next slide, please. Go all the way to the for completion of this slide, please. Okay. Instead of doing each of them in a silo effect, we need to build a tube between them so it can work all together with the purpose for the human. And finally, next slides, please. I want to show a picture of a father or maybe a grandfather. Look how he is trying his best to take a precise picture and also to maintain the safety of his baby or his grandbaby or whatever in that way. We need to be careful by taking a picture of whatever the issue which we are dealing with, and through the very good assessment, but also to be safe and maintain the safety of the society in that respect. And finally, next slide, please. I like to say, well, is we need to work globally as much as possible under certain topics and certain idea within the health and the production and food sustainability in that respect. And that where I really feel like is the current address of the antimicrobial resistance will fit very well in as a good model to follow with all of the other health issues that we need to consider. Thank you so much.
I am assuming the mic is still not working, so please write him that we will move to the next presenter immediately, the last one. And I know the audience is kind of squeezing out right now. So we'll just thank Professor Dr. Musliman for a wonderful insight on the issue. And we're looking forward to the next presenter. Please ask Dr. Sangeeta if she's available. And now we will start the slide show. We will not give post control to anyone else. Sorry.
Already does host. No, but yeah.
मुझे से रिक्वेस्ट कर दें कि वो होस्ट का स्टेटस जो है ना वापस ओके मुसलमान को भी रिक्वेस्ट कर दें कि सर अपने होस्ट राइट्स जो है ना नवीद यार प्रेजेंटेशन हमने स्टार्ट कर दी जो डॉक्टर संगीता राव की हमारे पास पीपीटी पड़ी हुई है स्क्रीन शेयर करनी है हमें
Even I am not able to share my screen. I hope you all can hear me.
Any text, yes, we can hear you.
Okay.
Yes, we can hear you.
So I shared my slides with Dr. Usman, and if he can share the screen.
She's not sharing. She's asking Dr. Usman.
I just shared it. Because my previous slides that I shared, I reduced the content to 20 minutes because it was more than 20 minutes in the past. So I just shared, and I hope this is the latest one, Dr. Usman.
Dr. Sangeeta, you are the host now. I think you can share.
Okay, give me just a moment. No, it is disabled. I'm not able to share. So I just shared my slides with you through email.
Dr. Sulman, can you, sir, can you please send us in an email so we will display it here? Because once we give voice right to anyone else, it takes longer time.
Which email address you should send my presentation? उनके पास ऑलरेडी वो ईमेल्स हैं तो वो हमारे पास नहीं है, हम करें।
एक मिनट आप सेंड करिए डॉक्टर अहमद DRAHMAD हमने फॉरन उस पे ये वाला होस्ट करना है at hsa.edu.pk. फॉरन उस पे होस्ट करना है तो हम बस यहाँ पे लैपटॉप पर पढ़ा भी यूज फॉरन बिल्कुल ठीक है जैसे रिसीव होती है जैसे मैंने फॉरवर्ड करनी है जितना लैपटॉप रखते हैं नवीद अपना लैपटॉप करें आप
Dr. Sangeeta, we are trying to load your most recent presentation.
Okay, thank you. So in the interest of time, since we are already like over the allotted time, so you want me to get started and then you could share the slides, please? Or you want me to wait for the slides to upload?
Give host rights to Dr. Sangeeta and if she can just start presentation. Dr. Usman, you're requested to remind Dr. Musalman if he can shift the host rights.
What do you want me to do?
We want you to give up host rights.
Host
I
rights.
am already. I don't have a screen.
So my slides are not shareable because I sent the email.
Dr. Sangeeta, they are trying to load your presentation that you have just sent.
Okay.
ये हमारे पास अपनी स्क्रीन अपनी ऑप्शन है यहाँ से हम स्क्रीन शेयर कर सकते हैं.
So can you see if my slides are visible? Because I think I got it now.
Yes, yes.
Okay.
We can see it.
Okay, thank you. So give me just a moment, please. Just bear with me. So are the slides moving?
Yes, ma'am.
Okay. All right. I really thank the organizers of this public health conference to come together and organize this and having me as one of the speakers. Thanks so much for doing that. So I'll just get started with the topic. So I'm not like spending more time here. So as we all know, and the reason we all gathered here is because antimicrobial resistance of pathogens is or has been an escalating global health concern and important for food safety. So in addition to causing like large economic losses, these pathogens, especially we always see about like Salmonella, E. coli, Listeria, all these infections result in increased or severe disease and longer hospitalizations in people. So we all understand the risk of AMR pathogens that they cause with the impacts on food industry and in turn for food security. But there's very less research done on occupational exposures of workers who are in constant contact with these animals to antimicrobial resistant pathogens due to their exposures on frequent basis, like in their working environment. So my talk is on these occupational risk of AMR in farmers and farming environments. So I've divided my presentation in these three areas. Like I'll talk about antimicrobials in livestock production, why they're used, and our previous presenters have discussed that a little bit. And addressing livestock worker health. And also I will talk about few slides about current work that we are doing with respect to AMR. So, as I said, AMR pathogens are global threat to human and animal health. And these data here, for example, salmonella, like drug-resistant salmonella, can cause, this is from the US data, from CDC, is that salmonella infections per year could be as much as 1.2 millions. And drug-resistant salmonella infections per year could be 100,000 about. And there are so much expenses towards like medical costs, etc. But we are not sure how much of it is coming from day-to-day exposures of workers to these pathogens. So yet there is a long way to estimate that. So setting up surveillance programs for diseases and even for animal health at a larger scale or even at a smaller scale would benefit overall health. So by implementing these surveillance programs, we're not only improving animal health, but also reducing disease burden in humans, especially zoonotic diseases, producing safe food, and contributing to economic growth. So AMR is one of the largest global threat in 21st centuries and requires urgent measures. And unnecessary use of antibiotics could be minimized and spread of antimicrobial resistance can also be controlled. So the associations or correlations, whatever we call it, between antimicrobial use and antimicrobial resistance, especially in animal production, has been firmly established based on many studies for decades together, based on observational studies, country-based AMU and AMR surveillance data. And one of our previous speakers talked about such platforms, and also through meta-analysis. So that has been established well. And increased AMR levels have negative impacts on not only on livestock production, but also increased costs and productivity. And it might lead to a threat to food security. So antimicrobials can be used in production animals broadly as like for treatment, illness on individual animals, controlling diseases, prophylaxis like as a preventatives, and sometimes also for metaphylaxis with an assumption that a disease could happen, and also for growth promotion in some of the countries. And there are some examples here that I've given. So it could be after the surgery or a dry cow therapy, before transportation, as I said, for metaphylaxis, or potential outbreaks, or in also stressful conditions. So in all these areas, antimicrobials could be used for animals, which could lead to antimicrobial resistance and become a threat to public health. This is a very broad transmission cycle that I put together, and it may not be just in one direction. I have provided arrows, does not mean it's just in one direction. It could be as a comprehensive transmission pattern that we could say. So if antimicrobial usage is done on farming animals and antimicrobial resistant pathogens are circulating in those animal environment, it could lead to the manure like coming from these animals. And sometimes you must have seen in some of the countries, especially villages, the manure is a very good source for not only fertilizing the crops, but also for cooking. So that becomes one of the risks for public health. And not only that, in the food products, those antimicrobial resistant pathogens could also lead away. And that becomes an occupational risk for workers in the farm, transportation, slaughter, and processing areas too. So the people who are working in these areas are in constant exposure, because at least 1/3 of the day they spend in the farms, thereby getting exposed to these pathogens, which might be antimicrobial resistant. And also these products and the manure we talk about could also contaminate the environment and also the sewage and water bodies. And it could lead to a potential threat to public health. And this all is encompassed in one umbrella of One Health that our previous speaker, Dr. Salman, mentioned very nicely about One Health approach. So all these components could play a role in the whole One Health scenario. So occupational risk to farm workers, we all know that bacteria and also other pathogens are known to be present throughout the production cycle of these farms, from farm to the fork. So the risk they present has been considered in concept of food safety, but not as occupational risk. So these workers or managers who are dealing with these animals on day-to-day basis to provide food to us include direct contact with animals and their wastes, working in an enclosed environment with high animal density. So we are just not talking about infectious diseases here. We are also concerned about a lot of work has been done in like respiratory infections, not only infections, but respiratory distress for being in that enclosed environment constantly by these workers. And not only that, operation of heavy machinery. So they might lead to trauma injuries of these people, not only animals, but also people who are working in that closed environment. And also assisting with taking care of sick animals. So I want to bring this topic of livestock biosecurity, which plays a very important role in occupational health of people and also occupational hazard to people. Not only that, but also infections that could happen to the animals. What exactly is biosecurity? These are nothing but a set of management and physical measures designed to reduce the risk of introduction, establishment, and spread of animal diseases, infections, infestations to, from, and within the animal population. So biosecurity is not just about limiting pathogens between animals, but also limiting spread from animals to humans and humans to animals. And we want to bring another terminology here is biosafety. It's about preventing infection to workers. So if we take biosecurity and biosafety as one whole component, then we are talking about not only health of animals within the farming environment, but also people who are working in the environment. So broadly, biosecurity can be divided into external and internal components. Why we want to divide them like this is so we can put some measures in place, prevention and control measures in place to be able to combat any of the diseases that could be a threat to not only the people, but also the animals. So for external components, I've listed a few of these here. For example, purchase of animals and animal products, transportation of animals, removal of manure carcasses, supply of feed, water, and equipment, access of these people and visitors from outside, and vermin and bird control, which could also lead to any infectious agent entering the farm environment, and the location of the farm itself. And internal components could be, for example, like how the disease management protocols are placed within the farm. And sometimes we see this all in, all out when younger animals are brought to the farm and they are taken out of the farm when they're ready for slaughter. And in between, the cleaning mechanisms happen in the farm itself. And stocking density, depending on like how much area the farm is and how many animals are being raised there. Compartmentalization and working lines, like how, and this is again a very big topic, I don't want to go into detail, but how compartmentalization of a commodity could be one of the areas that could be focused as an internal component for biosecurity. And cleaning and disinfecting, of course, this could be a component for external as well as internal. So one of the areas that one of our PhD student, Dr. Robert Fatke, is working on, along with Dr. Salman and me, is developing a tool to be able to assess knowledge, attitudes, and practices for biosecurity as well as biosafety of these people working in this environment. And why is it needed? Because we all know that effective biosecurity practices in livestock farming are important to prevent and control endemic and exotic diseases, including zoonotic diseases within the livestock populations. And when the biosecurity is inefficient, it severely impacts the markets and reduces food security because of the exposures of these farms to the diseases. And good biosecurity is associated with improved animal health, human health, economic performance, and also reduced antimicrobial resistance. And as I mentioned before, if the biosecurity practices are sound, then it improves food security, prevents antimicrobial resistance, and prevents introduction of dangerous pathogens into animal and human populations. So thereby what Dr. Fatke is working on is, along with Dr. Salman and me, is bringing this biosecurity and biosafety within the farm environment, which are right now like separate technically. And he's bringing those together under one umbrella like this, overlapping them, to be able to assess what the knowledge, attitudes, and practices of these farm workers and managers are, to be able to combat any disease that impacts not only animals, but also workers in the animal environment or the livestock environment. So I just listed here objectives of his work, which I'm not reading it, but the whole point is to have a comprehensive assessment tool to be able to assess biosecurity and biosafety within the farming environment. So I want to again bring another component of one of the areas that we've been working on, which is again brings the One Health concept of bringing animal, human, and the environmental aspect of it under one umbrella and focusing on occupational health risk. So again, as I mentioned before, these the cattle operations, they represent high risk for zoonotic pathogens for these workers. And people who are living in the farm or outside the farm and working with these animals and also having contact with their family members, that could also become a risk to the family members, which needs to be assessed, because that becomes a whole component, which is like we call it a cluster rather than taking it as a silos. And we need to be concerned about these workers taking or bringing AMR pathogens home and then exchanging between the farm environment, not only with their co-workers, but also with their families. So the risk is further compounded by multiple like antimicrobial drugs, which could be used in the farm and that people are getting exposed. So that is one area that we have the interest in. And we also know that behavior and practices of workers play an important role in the risk of exposure to these pathogens during any of these activities, any of the activities that happen in any of these farming areas. And again, the size of the farm itself and what practices are maintained in the farm itself plays a very important role. And we believe that the worker clothing, because these workers are constantly exposed, and if we sample the clothing of these workers, we might have some assessment of how much exposure or risk of exposure of these pathogens to the workers is happening. So thereby this study that we conducted helps us to understand that not only the distribution and diversity of AMR in Salmonella, we collected Salmonella samples, or we collected samples from clothing of these workers and isolated Salmonella to be precise. And we looked at the genomic structure of these Salmonella isolates. Not only that, we wanted to link them to the source of the isolate itself. So main objective was to, as I said, to identify and understand the epidemiology of AMR of Salmonella enterica. And we isolated Salmonella Dublin here, enterica serotype Dublin, from the dairy, clothing, and environment. So what we did was we collected samples from organic dairy and conventional dairy by one of our PhD students in the past. And then we isolated all Salmonella Dublins only from the conventional dairy and none from the organic dairy, fortunately. And what we did was we put a bib cloth, like a chest piece, on the people workers, and also a hand cloth and the gloves and the boot sample. So for each person, 3 samples were collected: chest piece, glove and the hand piece, and boot samples. Not only that, some of the room's environmental samples were collected from milk as well as the room itself. So just to very quickly go through the methodology. Once these samples were collected, they were transported into the laboratory in peptone water and sterile peptone water. And then Salmonella Dublin isolation and AMR characterization was performed following the protocols in the laboratory. I'm not going into details of those here. And then a DNA was extracted and whole genome sequence was performed, and we used Genius Prime program and blasted against MegaRes database for identifying the antimicrobial resistance genes. And we are now working on the identifying virulence genes from them. And briefly, the results were overall 23 worker samples. Like some of the workers were repeated because these are BIB. The chest piece is the BIB. Boots and glove samples are positive for Salmonella Dublin, and there were like 4 environmental samples that were positive for Salmonella Dublin. So the sample size was not a huge sample size, but we were able to find what could be the risk to these workers on day-to-day basis. So jumping into this pie chart, huge pie chart, where we divided each of these slices into different classes of antimicrobials, the highest being beta-lactams, 26%. And the next was aminoglycosides resistance, and multi-drug resistance was 14%. And we also found fosfomycin resistance. Fosfomycin is one of the drug of public health importance, and it is never used in dairy industry in the United States, but we found genetic components which indicate that there is fosfomycin resistance going on. So although this is 1%, but it is still of concern. So we are identifying if there is a phenotypic resistance of fosfomycin also existing, and we found recently that phenotypic resistance is also existing apart from genotypic resistance. So this is of concern how fosfomycin resistance could enter a dairy farm, although fosfomycin is not being used in dairy farms. So if we divide all the results that I showed you previously into the source of the sample, the chest piece, which is BIB, boot, glove, and environment, as I said, beta-lactams. So boot samples, beta-lactams was highest, whereas environmental samples, aminoglycosides was highest. As I said, these are not a lot of samples, but still of concern. And then multi-drug resistance, it's almost similar between boot and BIB samples. And the boot sample actually had fosfomycin resistance, the one I mentioned about. There were about 3 samples that were fosfomycin resistant. So that was a very brief presentation of the results. So overall, just to wrap up, Salmonella Dublin is prevalent on dairy worker clothing and the dairy worker environment. Beta-lactam resistance, which is of public health concern, and emerging fosfomycin resistance is an exposure risk. I put it as a question mark. We're still identifying those. And antimicrobial susceptibility testing, we finished the antimicrobial susceptibility testing, and we are comparing those results with the genetic characteristics. And we found strong associations that are not presented here. And we are continuing to do our virulence factor analysis. Thereby, overall conclusions is that antimicrobial resistance and food safety of animal origin is of one health issue. And biosecurity and infection control at farm level is one of the key factors. Antimicrobial usage and compliance needs to be better understood at farm food animal level, and continuing education on stewardship is the key. And just to have some strategies in place for limiting AMR and mitigation in the farm environment system, these are all the lists that we could think of. Like, for example, establishing effective surveillance systems involving appropriate data collection on resistant pathogens, and we can say frequent sampling, close monitoring of supply and use of antibacterial drugs, prescription based on sound medical and veterinary principles, such as laboratory results, strict adherence to drug withdrawal periods in food producing animals, which is very important to be followed. And antimicrobial agents should be restricted for growth promotion of these livestock. Improved hygiene, disinfection, and vaccination for prevention and control of infectious diseases. So following more preventative part of management rather than therapeutic. And again, strict biosecurity and biosafety protocols. So I went very quickly on the presentation due to lack of time. And if you have any questions, please feel free to ask, or I could share my email for any further clarification. And my acknowledgements to all of these institutes as well as the funding agencies. Thank you.
Thank you very much. Still, I think the technical problem is there that the speaker cannot hear us. So we will write him thank you message on the text. And I will really appreciate all the speakers and speakers who are here. And I know it's a really long day and still you guys are kind of pulling your guts and we are all here. And in addition to the AC problems, so yeah, I can admire the stamina of all of you. I think now probably we should move towards the closing of the session. And if there are any questions anyone would like to comment, please feel free. We can put the question in the text box and maybe the speakers can respond if there are any questions. So are there any questions from anyone right now? Okay, so we will just thank everyone who has participated in the session, and we will be moving toward closing it. And as a part of closing the session, yes. Sorry, I forgot. I would request discussant Session-2 to give his comments.
I think it was quite extensive. Thank you very much for giving me this opportunity. I think it was very well needed discussion to be generated on the antimicrobial resistance that we are having in Pakistan. We are very thankful to especially ministry itself. Oh, he's also focusing on. Unfortunately, I think so because of the technology that we have been facing, the labs and the technology that we have been facing, we are not directly interacting with the presenters. It was quite a lengthy presentation that has been given out, but very informative. And the work that has been going on all across the board is also being used as a case studies in Pakistan also. We are very thankful to Fleming Fund as well as Ministry and NIH for putting up for AMR that has been very much needed. And that was the only area during the JE report that was considered to be having the lowest number in terms of its capacity that Pakistan has. And over the years from 2016 till now, because of the efforts of especially, I would say, Fleming Fund, NIH, Ministry itself, up to an extent, USAID has also contributed in the first strategy document that was developed for containment of AMR. So we are looking into that within the next JE report that we'll be following up in the next year. Quite a lot has gone in, and we'll be having a good number of things that have been achieved by that time. Again, I would like to thank all the presenters for being patient with us. Because of the technology, we have not been interacting, but still, any question is, if they are on the part of the participants, we'll be putting into for the email so that they'll be able to respond to the questions or the queries of the participants. And participants also could get the interaction from the presenters. That's all.
Thank you very much, Sir Nadeem. I think probably now we can move toward having the picture. And before having the picture, we would just want to present shields to our honorable chair and speakers and discussant. So I would request discussant Sir Nadeem to be there in front of the banner. And I would first request Dr. Aisha to be here. And I would request Sir Nadeem to give the shield.
Okay. Yes. This is
Next, I would request Dr. Salman sir to please be here, and I would request Sir Nadeem to again get the shield and the back.
In any issues, taking up all these efforts also. I hope that the government is contributing much more.
Now, I would like to request Dr. Nashmia to collect the shield on the behalf of Dr. Nimesh. And I have request Sir Nadeem to again present the shield. Or we can request Sir Salman to be here and present the shield. Yes. 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 Now I would request Dr. Usman Zahid to collect the shield on behalf of Dr. Samuel, Professor Musalman, and Dr. Sangeeta. And now I will request Dr. Salman to present shield to Sir Nadeem.
Yes.
Now I would request all the members to come in for a group photo, please. And in the group photo, I think we can have a seats in the front where we can put our speakers and chair, and the rest of us can stand behind it. Okay, I think one without mask as well. Without mask? Yes. Thank you. Thank you so much. Sorry for the technical